Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program, and welcome to today's program. I'm going to do our little welcome slides here, and I'll pass it over to Dr. York. Again, webinar tips and notes. As you joined, your phone or your microphone were muted. Please use the chat function for questions and answers. We'll be keeping an eye on them. We'll have a post-webinar evaluation. Again, go ahead and fill that out. This is where we get a lot of ideas for upcoming webinars. CME's, of course, credit is available for watching the live presentation, and I will be sending out the thank you email. So don't worry about grabbing all the web addresses and whatnot. I will be sending out a thank you email with all of this information in it. And then if you have questions, you can reach out to me directly. This was also on the registration page. These are the continuing medical education informations, the objectives, accreditation statements, financial relationship statements. I'm not going to read through them. We'll continue on here. Of course, our standard disclaimer. Let's read that. Okay, that's good. And please be sure to check our website for upcoming events. I believe this email I sent out, we had 3 of them. We got all 3 dates secured for July, August, and September. So check that and make sure you're registered. Again, your opinion is valuable to us. So please go ahead and do that evaluation. It'll pop up behind the screen automatically. And I will send out the URL in my thank you email as well. All right, so I'm going to go ahead and introduce Dr. Larry York, and he's going to talk about Dr. Smelsky and part of our series. If this is your first time joining us, Dr. York?
Yeah, so I hope that we have a lot of new people today. This is, I think, a record for us. But if you are new to us, this has been a lecture series going on for a couple of years now. It's crazy to think it's been that long. But talking about envenomations, intoxications, travel-related diseases. Initially, we had focused more on the Southwest. We try to keep it there as much as we can. But really at this point, a lot of our topics, other than today bringing up things that I think are very timely, very important, clearly I think of interest to a lot of folks. But we're really trying to cover things that we think will be of interest to all of you. And truthfully, at this point, I would say probably 20% of the topics we're covering are things that have been suggested by you all in the evaluations that you get. So please, do take the time, let us know if there's anything you'd be interested in. Admittedly, we've got quite a library built up at this point of talks that we've done. So if you're interested, you can always check out the things that have been done in the past on the University of Arizona Telemedicine website. Well, we talk about anything. We've got coccidioides, we've got rabies, rattlesnakes, antivenoms, plague, which is pretty timely now. We've had a case here in Arizona of plague come back up. Hantavirus, waterborne illnesses. You think of it, please put in that eval. We would like to cover it for you. But with that said, I'm going to introduce or reintroduce Dr. Jeff Smelsky, the Clinical Education Director of the Poison Center, who's going to update us today on rattlesnake bites. Take it away.
All right.
Thank you.
We're going to go ahead and get the right screen up for Dr. Smelsky here.
Okay, that's helpful.
That would be very helpful, yes. Take it away. I'm going to go ahead and give you the control of the mouse, and there is your arrow.
Awesome. Well, thanks for having me back again. I've come a couple of times, but this is probably my more of my bread and butter here. So we're going to talk about management of rattlesnakes in the hospital, and we're going to talk about some of the after hospital discharge complications. And so I've done a lot of research the last couple of years trying to get a better understanding of this. So if you've seen my other talks, there's a little bit of overlap just so that folks have some background in case they hadn't, but most of it's going to be new and most of it's going to be focused on stuff we do as far as decision making for folks in the hospital. This is in my contract, right? Like I have to put these disclaimers and advertise for the Poison Center because that's where I work. So we do a lot of good stuff. Not everyone knows all the things that we do, but we're part of the Department of Health. The stuff in red, that's me, and that's the stuff that I oversee for the sake of the Poison Center, amongst the things the state says we have to do for being a Poison Center. So I do a lot of the education, a lot of the data collection and the research that we do, and our Poison Center records. But a lot of different folks there do a lot of good things. And so this is a video from last year. So look for the snake. It's on there, obviously, since we're talking about snakes, and it's an awkwardly long video on purpose. So someone's going to get bit, otherwise I wouldn't have put this on there. If you haven't found the snake yet, it's that stick looking thing in the bottom in the middle of the screen. And so this is from a ring cam. And so Dad has already walked right past the snake, which is what turned the camera on. Now, I love this video for a whole bunch of reasons, but I use it for the sake of rattlesnake behavior and so that folks understand what rattlesnakes are. And no, it wasn't the dog, not yet at least. You know, and so a lot of folks think that they're aggressive or that they attack, you know, but they're terrified of us. We're giant lumbering beasts. And so their number one defense is to just pray that we go away. And so, wasn't her, wasn't the dog. And I always feel so bad for Mom because she's the last one. But this sums up our kind of most common patient. It's someone that didn't know the snake was there. The snake tried to do its thing. It tried to just wait for us to go away. And then it got so nervous that it started to rattle. And at some point it starts to strike out. And so we walk past them all the time in the desert here without really knowing that they're there. We can coexist somewhat peacefully for the most part. When that doesn't work, then they end up becoming one of my patients. So how do you know if it's a rattlesnake or not? The biology folks love all these great little details about things on the face like elliptical eyes. And you know, the reality is if you can see any of this stuff, you're too close to the snake. If it has a rattle, it's a rattlesnake. They're ambush predators. They're not likely to be out and about. If they are, they're going to do what that snake did. They're going to pretend that they're a stick and pray for you to go away. If it doesn't have a rattle, it's probably not a rattlesnake. Try not to get sucked into the two stuff because once you see it, there's a really good chance that you should not get bitten unless you accidentally back up into another rattlesnake that you didn't know was behind you, which has happened. This I touched on a little bit last month when I gave the talk, but kind of our patient population who gets affected. Again, most people aren't aware that the snake was there. Most people are at home. Most people it's in the afternoon when they get bit. And one of the things that I've been focusing a lot on is this disability and the recovery time frame. So most folks don't appreciate how long it takes to recover from a snake bite. And a lot of the evidence, a lot of the medical literature that's out there really focused on mortality as the major outcome, which is fantastic, except it's been less than 1% for a really long time now. And there's a lot of stuff in the morbidity area. So threw this in for you guys, and we won't go too far into it, but if you look at the 14-day recovery, that's kind of the primary endpoint that I use for a lot of the work that we do. And you've got people that have a full recovery versus people that have persistent physical injury. And so, you know, most people over half at 14 days, but when you expand out and you go down to the 90 days, you know, you still have more than a quarter of the people that have been bit are still having pain, swelling, function loss at 90 days. And if you go out to 6 months, you know, it's around 10% at least, we start to lose more people out to missingness. But the reality is that there is a portion of our patient population that are essentially having a permanent injury from this. And so, you know, if this is a 20-year-old or someone that's got their whole life ahead of them, this is a very life-changing event. And so a lot of the work I've been doing is trying to better understand that and to see if we can kind of improve the recovery. I love this video because it compares the venom extraction from an adult versus a juvenile. So the adult's on the right and the juvenile's on the left. And lots of folks tell me that, you know, they'd much rather be bit by this giant adult snake than a juvenile because they hear these things about juveniles can't control their venom and whatnot. And so I give them a visual as far as what venom looks like from an adult versus a baby, because when we start talking envenomation basics, the severity is very much driven by dose dependent. And so I would take the baby snake every day of the week. But we'll kind of cover the envenomation basics. So the mechanics of what's going on. You've got a bunch of venom toxins inside the snake's venom gland, and there's a bunch of different things in there. We'll cover what they are in a minute, but a bunch of different things, and there's a lot of variability even within the same species. And they're somewhat inactive. They're not causing any problems for the snake, and then they get deposited. Most of the time it's a subcutaneous bite. Other things happen if it lands elsewhere. Most of the time that's what we think is going on. And then the sequence of events starts to unfold. So you have these really small molecular sized toxins, and those get absorbed directly into circulation for the most part. And so if they're present in that particular snake's venom, you get this early onset of things. And a lot of the systemic toxicity that you see happens very quickly after a bite. And we'll cover the specifics in a couple slides as well. And then this secondary kind of onset starts to occur. And so those small molecular weight toxins and the pH of the area, because snake venom is super acidic by comparison, really control that inactivating of the larger toxins. And so when those things change, those larger toxins go into these structural conformation changes that kind of activate them, so to speak. And so the local tissue injury is primarily driven by those. And so then these things become active, and then this process of inflammation sets in. And so what snake venom does that's somewhat fascinating in a terribly malicious form is that it evades our immune response, and it kind of plays our defense mechanisms against us. And so it creates this inflammatory response from an injury, and then it damages the vasculature. And so our containment efforts, the things that contain swelling to a localized area, get evaded. It goes through, and then it causes more inflammation. And then it does, and it repeats this process of causing this progressive inflammatory injury. And so it's like it biologically evolved to, kind of evade our defenses, and it works really well. And most of the damage is actually us, our own inflammatory response causing a lot of the damage, which is an important piece to keep in mind, because when you talk about antivenom and the treatment for it, antivenom doesn't stop endogenous pathways. And so your efficacy for local injury is pretty minimal. So we'll dive into that in a little bit, but bear in mind, you kind of have these variable onsets. There's a bunch of different toxins, and it kind of keeps doing this cycle of getting contained with inflammatory response and then kind of damaging the vasculature and expanding. And so you get these kind of leapfrogging things. And so if you look at what toxins are here in wonderful Arizona across our 15 species, it gets super complicated. So we got 24 toxins, 15 species. And if you're really nerdy and want to know the details, they're all on that chart right there. Most people don't want to. I don't really want to know them, but I do. The point of kind of throwing this in is really just to recognize, like, one snake bite is one snake bite. There's a lot of different things that can happen. There's very good, clear reasons for it. We just don't necessarily have a venom profile of the snake that bit the person, when they come into the ED. And so instead of being able to predict exactly what's going to happen, we kind of have to look at a bigger picture and know all the different things that can happen. And so if you look at the symptoms that we get, and we're going to go into this with some pictures and stuff, because this is way too many numbers for most folks. It kind of groups into systemic inflammation, things that are affecting the whole body, and then kind of this local inflammatory response. And most of what venom is doing is driving those two different things, trying to facilitate more venom entering into systemic circulation. If venom, ultimately kills a human, it's always through shock. There's obviously other ways that it could get there, but mechanistically, this is what it's trying to do, and it's rather effective at doing it. So let's look into some specifics. So when it comes to systemic toxicity, somewhere around 10% of folks will develop some type of significant symptoms where we see it. These videos are showing myokymia, which is this neuromuscular activation that it causes. We don't actually see paralysis here. If there was a big enough dose of venom, it would certainly lead to paralysis. Dogs in Tucson get paralyzed. Our size just happens to be in benefit for us. If there was a small enough child bitten by the right snake, I would expect paralysis to be possible, but clinically, we just don't see it in the humans that we see in the hospital. But the ultrasound is up there. So sometimes these are subclinical, meaning that you can't actually visualize them externally. I have a whole bunch of mechanistic hypotheses about how this stuff makes things worse as far as damage to the tissue injury and ultimately the recovery time frame. But this is what it looks like for folks that have never seen it before. If you want to look at that local injury, it's pretty nasty. Like I said, there's lots of different ways that it can manifest. There can be lots of histamine, and so you get the super erythema up in the top right. Sometimes it's just a bunch of edema because the capillaries are getting destroyed. And so, the various presentations can be rather different. We always ask the folks that are sending us pictures to make sure send a picture of both limbs so that we can compare and you can kind of see. But it's a pretty nasty tissue injury. This can travel up into the torso for a number of folks. We also get a lot of vascular damage, like I was kind of mentioning. So this is the very contiguous from the bite site. And so it's traveling through, damaging the capillaries. You get all sorts of bleeding internally that can result from it. Coagulopathy, the stuff that thins out the blood, kind of worsens the internal bleeding component to it. And just kind of some pictures for folks that hadn't seen it before. And I like to emphasize, again, there's a lot of different toxins. They all have different mechanisms, even though they cause the same thing. There's this really kind of interesting overlapping redundancy with what venom is trying to accomplish. It just has one goal of causing shock. It gets there a lot of ways. And so you see the direct tissue injury. So the poor lady's arm on the right there, that's 4 hours apart with anti-venom running the whole time. The lady on the left didn't have that vascular injury when she was discharged from the hospital. So it also causes this intracellular apoptosis mechanism of vascular injury, and it's not necessarily contiguous from the bite site. So you can see the bite on her foot. She was discharged. She woke up the next day and was bleeding into her thigh, as you can tell from the massive damage to the vasculature on her thigh. Day before there, nothing was there. So we look for a whole bunch of different things on different timing onsets. Unless you kind of have the full picture of what can happen, it's easy to get surprised by things that you weren't expecting. So I throw this in there to pause for a second in case I went too fast. We're going to talk about the hospital management and some more specifics for folks in a minute, but if there's any questions in the chat, I can answer them, or we're good. All right, everyone's awake enough, we'll keep moving. So let's talk about treatment recommendations. So as far as pre-hospital stuff, the answer is just no. EMS folks, I give this talk to lots of EMS folks. They always have these convoluted, like, if you were in the side of a mountain and didn't have a sat phone, and when would you do a tourniquet? Like, I guess you could come up with some scenario to get me to say, yes, that might be a good idea. But the reality is, like, you're probably going to lose the limb if you're putting a real tourniquet on. And if the venomation wasn't going to kill you, then you just like chopped off a limb for no apparent reason. Personally, I wouldn't go for the tourniquet, and we kind of stick with this, just don't do it. We suspect that most of these things just worsen the local tissue injury. There is certainly the, super hypothetical, if you had that massive envenomation and had all that systemic stuff off and you immediately cut off all circulation, it could be a life-saving endeavor. But like, if you knew you were going to be that like less than 1% person, it's kind of a risk benefit thing that I just don't advocate for. So we still see it. There was things like the Boy Scouts of America said, cut and suck for decades. And I still have people that come in and they tell me, like, just like the Boy Scouts told me, I pulled out my pocket knife and cut it out and sucked it out. And it's a lot of work trying to dispel myths that get so placed out in the community like that. So we try and get a lot of current education out there. I do a lot of stuff with the park rangers and try and put modern information out there. But just to answer it directly, no pre-hospital stuff is currently advocated for at this point, unless you happen to be one of the folks that gets pre-hospital anti-venom. So you don't do any terrible ideas prior to coming in, and then you come in because you got bit by a snake, and then you look like this. How do you know if it's an envenomation, right? And so this whole dry bite question comes up a lot. And some folks have really rapid onsets of symptoms, and that's very obvious and easy, and you can kind of skip over this step. But you get a lot of delayed onset effects, and then you have other things that go into it. So there are snakes that mimic rattlesnakes. They have a triangular shaped head if you didn't catch the rattle. And there's a good number of people that never saw a rattlesnake. They just felt a poke, or they heard something and they didn't know what it was, so they came to the ED. And so, how long do you stare at a person with a cactus poke before you say it's not a rattlesnake and it's truly a cactus poke? And so this is kind of our practice for it. So we treat everything like it's potentially a rattlesnake bite if there's any possibility. So you start with the basic wound stuff, wash it off. Lots of folks come in with dirt caked on, and we joke with the fellows that come and train at our fellowship program that you're going to wash a lot of feet as a fellow here, because people get afraid of rattlesnake bites since they don't do basic stuff like wash off a puncture wound. So wash it off, clean it off, just soap and water's fine. Don't do anything crazy. And then you can start circling with a marker on it around the inflammation. If there is any, if it's like this and it's super minor, you can throw a time of bite or something on there, but just treat it like a puncture wound and start the basic stuff. The observation period, the full period is 12 hours. That's what we say. There are some small exceptions that are later than that, but 12 hours is going to capture the vast majority of folks. But really a dry bite is a diagnosis of exclusion, meaning you have to wait for something to happen, and only when you've decided that nothing has happened can we say it. We have no way of confirming positively that there is no venom there. So you kind of just awkwardly sit around and check for stuff. So our local injury, we do anything that's beyond what you would expect from the mechanical puncture. And so if you're giving IV opioids because they're talking about 10 out of 10 pain, like that's not a cactus poke. That's something more than a cactus poke. You believe them enough to give them some Dilaudid, like potentially suspect that it's a rattlesnake bite and kind of consider the antivenom. The coag labs are the most objective way to do it, sort of. So fibrinogen is great in that most of the population has a normal fibrinogen level. People that have afibrogenemia, as far as the genetic baseline, tend to not live terribly long. They tend to not make it out of the teens. And so there's only a very small portion of the population where you might capture that. So fibrinogen is pretty reliable. The INR is usually affected after fibrinogen, so it's not necessarily more helpful. You could have folks on Coumadin that limit it, but if the INR is abnormally high, then you know that there's a bunch of venom circulating around. Platelets are probably the least useful. Lots of reasons for baseline thrombocytopenia. We've tried to grow platelets with antivenom a bunch of times and it hasn't worked yet, so I don't advocate for it. But if you don't have baseline thrombocytopenia, low platelets can also be another way to tip you off. So sometimes the labs are helpful, but less than 50% of the time. So local injury is kind of the primary thing that we diagnose envenomation off of. If you have signs of an envenomation, we say give antivenom. That's been our mantra for a really long time, prior to my coming here even. Part of this is because it's a preventative measure, right? So you can't fix anything that's broken. And if most of the stuff driving the pathology is our endogenous pathways, waiting until all that stuff starts and then giving antivenom is probably not in the patient's best interest. So we have a really low threshold to starting antivenom. We get a little bit more cautious for the sake of throwing loading doses on top of loading doses at people, but we start antivenom in everyone rather quickly. This is kind of our protocol for it. So we define control of the envenomation as the edema progressing less than an inch an hour. Somewhat arbitrary, but we've been using it for decades and it seems to work relatively well. And either a normal or normalizing lab values. So if they're in the wrong direction and then we give antivenom and then it's get better, that's reassuring. But those are the two things that we look at, and we keep giving loading doses every hour until we get to that point. So I've got our average dosing for both Crofab and Anavip on the left there, but most people get 2 loading doses. It's kind of the standard. Some folks get 3. We get a little bit cautious about going beyond 3 loading doses and suspect that most people don't need it. You know, sometimes the history might suggest it, right? If you've got 3 bites by 2 different rattlesnakes, like perhaps the dose requires a higher dose of antivenom. So we do factor stuff like that in, but 2 loading doses tends to be sufficient for most folks. The 3rd dose tends to be a little bit more ambiguous, but again, we kind of err on the side of giving as far as not giving. The loading doses of the Anavip, we give 10 vials as the loading dose. We recommend that everyone in Arizona gets Anavip simply because of the late coagulopathy and venom recruiterance problem, but I won't dive too far into that. That's our standard. Anyone not getting that has a lengthy discussion with me about Crofab and kind of laboratory monitoring outpatient that it would require to do. So most people here just get Anavip. Some people get both, which is kind of a novel area that we're exploring because we think both have potential benefits. But Anavip's what we make sure everyone gets prior to discharge. If folks were to be treated with Crofab only, there's this maintenance dosing thing that happens. I assume most folks probably don't know this, but in the clinical trial back in the 90s, Crofab was given with the loading doses, and then there was this kind of and PRN group versus this and scheduled group. And so the and scheduled group had less late tissue injury onset. They arguably had none compared to like half-ish of the PRN group. And so maintenance doses were born as this kind of standardized thing. Whether or not they do anything is a very debatable topic, but it exists. We've used them the entire time that Crofab's been out as far as recommending them. Again, you can have lots of discussions on it, but that's where they come from. That's what they are if you're using them. Loss of control. So because you have this dose of venom and it's activating and all these different toxins have these variable onsets, you may get control and then kind of lose it. And so we have this, do you give loading doses or do you do these kind of mini dose things? We typically use just loading doses, depends how much antivenom they've already gotten. And so we tend to use the 10 vials of Anavip or another 6 of Crofab, but 4 of Anavip is in the package insert, not terribly great guidance on when to use it. You could consider just doing maintenance doses with Crofab. People do different things on it, but we define control as being maintained for 18 hours, essentially is what we're looking for. If you go 18 hours without anything getting worse, that's kind of when we decide that you have been treated. We reassess hourly for the first stretch of time, and then it kind of moves out to about every 2, and then eventually every 4 hours as we get up to the 18 hours. But if any signs of envenomation recur, we restart that 18-hour clock again after antivenom ends. Let's see. So antivenom is part of it, but there's a lot of other stuff going on, especially from the patient's perspective, which is, again, some of the work that I've been focusing on. So pain control is probably one of the biggest things. We get some really awful pain. In fact, I put a paper out last year talking about opioid refractory pain. You know, if you're given fentanyl 100 scheduled hourly and breakthrough oxycodone to an opioid naive person, like that's a really awkward amount of opioids. And it happens in like a quarter of our patients where they're getting these huge doses of opioids and very little pain relief from it. So I've been exploring some other methods as far as analgesic control goes. At this point, we don't put anything out where we say, hey, everybody can get this, but we have been somewhat liberal with using NSAIDs, which is a rather novel idea in snake bites. So we usually do a bit of a patient-specific assessment, but most folks get a thumbs up for the sake of getting Toradol. That seems to work wonders by comparison. For folks that wanted something that I could more blindly recommend is probably safe, benzos work rather well. We do suspect that a certain amount of anxiety is contributing to the pain in some of these folks. We've had all sorts of different lidocaine applications, topically, patches have been used. Ketamine has been used successfully in a few patients as well. But we try and recognize that pain is one of the major things. Poor pain control after hospital discharge is the leading cause of returning to the hospital. So we try and make sure pain control gets done upfront early, and we also try and make sure that they have adequate pain control for post-discharge. Wound care, so your basic stuff from a puncture. So tetanus can happen from snake bites. Hasn't happened in forever as far as I know, because we're really good about giving tetanus vaccines in the ED, but if someone managed to slip through, it certainly has happened in the past and could happen again. As far as the prophylactic antibiotics go, we don't believe that there's any need to do prophylactic antibiotics. Can make an argument if someone cut into it or did something to manipulate the wound, that might be the time that I would consider giving them, although you could also just do empiric antibiotics, which we have a somewhat low threshold to starting. It's tough. It looks like a cellulitis, right? It's our inflammatory response. And so we know that a number of folks get empiric antibiotics, and we know that only a small number of folks end up getting like culture positive infections. And so how beneficial is that group that's getting empiric antibiotics? We don't really know. But more than half of folks don't get any antibiotics. So again, kind of have a low threshold to starting them, but we aren't proactively recommending them in most folks either. It's kind of what we're navigating for what we've got. Blisters in blebs form, we typically recommend lancing or de-roofing them. Venom can get trapped in them. They can be super painful for folks. And so we do tend to recommend opening them up. Wound care literature tends to go back and forth, and people have different thoughts on it. So we don't necessarily have to open everything, but if it's painful, we tend to be a bit more aggressive about recommending opening them up. We do have a small portion of folks that develop these kind of persistent necrotic wounds that end up requiring surgical debridements. It's not a large number of folks, but the number of folks that have it tend to have multiple surgical procedures, and the necrosis tends to persist for months. So the folks that have it, it tends to be really problematic for, but most folks don't end up developing too much necrosis. We have also started to appreciate the prothrombotic effects of hitting Virchow's triad, of having a tissue injury and immobilizing stuff, and kind of hitting all three of those things. And we've had a handful of folks develop DBTs, and in fact, the unfortunate lady in the video at the front of this developed a DBT and a bilateral PE. And so we've begun doing DBT prophylaxis in folks. Again, we don't have any broad recommendations out there, but we're pretty able to make patient-specific recommendations for everybody. And so we tend to start DBT prophylaxis in most folks at this point. And so we get the pain control, we get the wound care stuff, we get through our kind of 18-hour window, and this is the criteria that we use as a generalized thing. There's obviously some exceptions for particular patients, but to give folks an idea of what we're looking for, we want the progressive edema to be stopped for that 18 hours. We want labs to be looking good. We want them to have some type of PT or OT assessment. For most folks in Arizona, this is the only time they may have access to that. We have a lot of folks that live in rural Arizona that don't have access to these things. We also have people whose lifestyles and their ability to get to a place is super minimal. And so that 5 to 10 minutes that they get in the hospital might be the only physical therapy that they've got access to. And so we're pretty big advocates for getting someone to see them prior to discharge, no matter what. We have a bunch of references that we've put up on our website to kind of guide folks, and we have some discharge paperwork that we give folks to give them some examples of what they can do as well. But we suspect this is a big part of helping people recover. We have folks that need walk assist devices, so basic stuff like that, things that you think of in your transitions of care, we try and stay on top of. And we want everyone to follow up with their primary care in about a week. There's a couple of delayed onset complications that we see, and so we want to make sure that someone's gonna check in on them. So as far as what they are, we have these non-healing wounds, and this is the area that I'm currently researching right now. So you get the giant red question mark. I guess I'll let you guys know when I do. But I know that there's some portion of folks out there that have them, and I don't know who they are or why, but I would like to know more. We know that those serious infections are pretty minimal. Those folks tend to have them prior to hospital discharge, so it's a little less concerning post-discharge. Most of the clots that happen are after hospital discharge for whatever reason. And so we do keep an eye out for this, and we send a number of folks back in for DVT screens. We have this insidious anemia group where they have some type of spontaneous anemia from internal vascular damage and then bleeding. Significant, hemoglobin's less than 7. So this is life-threatening bleeding internally. Not very common, again, just over 1%, but we're looking for them. And so we ask questions about anemia, right? Or your shortness of breath, do you have fatigue, these types of things. Serum sickness depends how you want to label it. So rashes are super common in everybody. That's where this 40% comes from. If you talk like more classic flu-like syndrome or a severe serum sickness, that's more like 10% or so. Again, depends on what box you want to put as far as categorizing it, but most folks have something, only small number of folks end up getting like steroids or antihistamines for it. Again, I have to brand for the Poison Center, and so this is our standard practice. So we do these follow-ups. We follow with patients pretty much every day. I say every 1 to 2 days, but it's pretty much every day. We're pretty obnoxious for a couple of weeks. And then we follow up with them. We make sure that they get access to the care that they need, right? If they're having problems with wound care and don't know what to do, we help facilitate that for them. Once everything seems like it gets situated and it's just a matter of the functional recovery, we switch over and we follow up every 90 days. So they either ask us to stop calling them or they tell us that they've gotten all the way better. And so we have folks that we know of that are a couple of years out that are still symptomatic because the vascular damage just never healed. I do a lot of standardization as part of my role for the Poison Center. And so we collect a lot of what's called real world evidence. So we systematically collect data and capture patient experiences to try and, qualitatively characterize it for the community. So at this follow-up appointment with the primary care, we screen for a bunch of these things. We also have guidance documents for primary care providers that walk them through what we're looking for, have our direct line to kind of call us and help them walk through it. Because, they might see one patient a year with this. Like, how do they know? Most people have no idea, even if they see tons of patients. And so we try and give them some real clear, direct guidance on what to do about things. Hopefully I kept on time. I'm super talkative, so.
Oh,
No,
we've got
yeah.
plenty of time.
All right.
Looks like we've got some questions over here. Let's
dive in.
Scroll.
So the first one I
Yes,
saw, I
right
think, was
here.
just a hair above, and I think it was, how many get bitten by coral snakes?
So coral snakes, we don't get calls on very many coral snakes. Part of that is that the Arizona coral snake is so incredibly small, it's like physiologically almost impossible to get bitten by it. The only symptomatic coral snake bite I know of personally was a physician that got bit on the webbing between his fingers as he was taking a coral snake away from his kid. And it was just one of those, like, everything lined up perfectly, but like even a finger getting bit on the side of the finger is almost physiologically impossible.
Do people have them as pets then?
Not that I'm aware of.
Okay.
I wouldn't go handling them, like at some point it could happen, but we don't encounter coral snake envenomation very much here at all.
All right, so we got another question here.
All right, so let's see.
Oop.
Oh, it's a thank you.
What is it? I didn't bring my glasses, so.
Oh, so it's just someone sharing a story that their brother was bitten by a rattler in their second toe this spring. They weren't getting good care in the emergency room, no anti-venom. So they called you guys and you actually recommended what to do, and I think Stiller Palmer was first.
Yes.
So thank you for that.
You're welcome. I know exactly who you're talking about because I'm the one that talked with them. So it was a complicated situation. I'm glad that we were able to kind of help them, but Yes, there's lots of misinformation out there, lots of frustrating circumstances for patients. Lots of providers that have limited information that are forced to make decisions that, it's difficult to find reliable information because I can find you a resource that says do this, and then I can find you one that says don't do this or do something else. A lot of misinformation out there.
Very cool.
Yeah, here's one.
All right, so are the various water snakes venomous, and how likely are water snake bites?
Well, so I'm in Arizona where there's not very much water at all. There are plenty of water snakes that are venomous out there. I just have no personal experience with them. So I could throw out some anecdotes, but I try not to do that too terribly much.
All right, no worries. And here at the bottom, so any extra information or points of interest, they specifically ask for stats or level of care recommendations for pediatric patients.
So for peds, we don't treat them differently with regards to like the dose of antivenom. We kind of have this dose of venom, dose of antivenom mentality around it, and we presume that it needs to be the same. As far as the kind of like clinical course and outcomes, my experience is that kids, little kids especially, get super sick really fast, and then they recover really fast as well. And so they tend to have the fastest, highest peak severity, depending on how you want to define it. And then they also tend to have the fastest full recovery.
Hold on here, moving our screen.
We are bouncing all around here.
What's going on over
Sorry, all right,
here?
here we go. Get the chat up. There we go. Now we're looking at the camera. All right.
All right. Do dogs have a decreased response and recover more quickly?
So I have so many questions for the vets in Tucson, and I just started talking with one this week. So animal envenomations are fascinating to me, and there's a lot more kind of evidence base for them because not all envenomated pets get antivenom. And so you kind of have this untreated control group that we don't have with humans. So the biggest takeaway is that they're much smaller than us, and they're far more likely to get bit in places that can compromise the airway, like dogs get bit in the face all the time. And so the local swelling becomes a circulatory problem just because of the proximity to it, where it's very rare for humans to get bit in the face, head or neck. It happens, but there's obviously logistics that get to that. So it's not super common. And so their outcomes are much worse. Their mortality is a lot higher, and then they're not necessarily always treated. So there's lots of things out there when it comes to the pets.
Well, speaking of pets, part of the antivenom is the host animals, one was a sheep and one was a horse.
So Crofab's made with sheep and Anavib's made with horses. YF was made with horses prior to Crofab as well.
So if you're out riding your horse and your horse gets bit.
So horses get bit as well.
Then what happens?
Well, whether or not they have a reaction to the antivenom, I would have no idea. I do know that horses tend to die from rattlesnake bites for whatever reason. Again, I'm not a vet, so don't quote me terribly much on this, but it's something I've heard multiple times now and suspect may actually be true. But lots of different animals get bit. We do get called on it, but there is an animal poison control center as well, and so we refer folks to them.
Okay.
But cows get bit, horses get bit, dogs, chickens. People have animals that are domesticated that get bit, and so they call.
Just. All right.
How weird that you get such different responses?
I just thought it's interesting if a horse
Yeah.
gets bit, but yet you use a horse as the host to create the
It
antivenom.
only grows more powerful.
Okay,
No, it's like the complete opposite, maybe.
I don't know. All right.
All
Next
right.
question here.
So how often does rattlesnake envenomation require transfer to tertiary care, like an academic medical center,
Oh, yeah.
versus just sticking at a small place?
So whether or not it is needed medically is a great distinction point. So we do have a good number of folks that get transfers, and I used to know the number off my head. It is in one of the papers I published last year, but I'm gonna guess off the top of my head around 40%. Now, most of those probably didn't need to be transferred. I would say if you have systemic symptoms like you have shock, those are the rare cases that end up becoming fatal every now and then. And that's where you would probably want to be at an academic medical center. And so those times I would say should be transferred, especially because you don't know how bad it's going to get because it evolves over time. Most of the people that are getting transferred are being transferred because the hospital that's treating them doesn't have that much antivenom. They have a couple of loading doses. And I do a lot with PMT communities about, stocking antivenom, and like you could have two patients at the same day that got bit by the same snake. Like you have to have multiple doses of antivenom to at least cover that load time, because if you have to wait 4 hours before starting antivenom, right? Like now that time to antivenom is getting huge and the benefit to the patient is getting dramatically reduced. If not completely gone. And so most places that are outside of the major cities, outside of Tucson, outside of Phoenix, will just give a loading dose and then transfer someone to either Tucson or Phoenix.
All right.
Very inefficient use of resources.
And is there a shelf life of the antivenom?
It does have expirations. I believe that both manufacturers will replace expired antivenom for free though.
Good to know.
Oh.
Good to know, especially. in
That
our
was last
rural
I had
areas.
heard.
Okay, all right. Next question?
Well, and it follows up well
Yeah.
to the next question, is it true that some fire stations have antivenom available in rural areas?
Yes, so there are some places that have pre-hospital antivenom as part of a study protocol. So it's not routinely available, you just happen to have to get bit at one of these places that particular service is at, so. Like once or maybe twice a year, you'll see on the news that someone got antivenom in the field, but it isn't broadly available, there's. This kind of lack of safety that has concerns raised about it as far as like it being more broadly used.
Okay.
I have different thoughts on it. I think it's probably safe to use, but as far as everyone else being on the same page, it's a very different story, so. This pilot study, so to speak, again, they're treating 1, maybe 2 people per year at most, and then kind of building up some safety data on it, but.
Right, so the next one looks like it's more to do with a vaccine, so. In Nevada, vet does not recommend the snake vaccine for my dog because he says that it's from a snake that is not in our area, so it likely won't help the dog if they get bit. And the side effects of the vaccine can be worse than the protection.
It's a great question. So I do intend to ask the veterinarian that I'm starting to work with this specific question, because I've heard arguments on both sides. And I'd love to get the experience from someone that's treated folks directly. I have asked some of our Tucson vets a few years ago. They tend to lean towards recommending it, and then they tend to point out that you also are still going to need antivenom, that this is not some type of immunity, but they suspect that it's beneficial. However, the vaccine is made with Western Diamondback venom, and that's what's biting most things in the Tucson area is Western Diamondback. And so you've got the most direct relationship between vaccine in this case, and the toxins that are being exposed to. So as you go elsewhere, like, does it change? Like, there's some changes, whether or not the effectiveness maintains or not is a great question. Relies on this concept called paraspecificity, or I think of it as just cross-reactivity where it works, but we never have antivenom or a vaccine from the snake that bit someone. And so it's always got this certain amount of like cross-reactivity it relies on for it to work. And not everything works. There's a lot of limitations to antibodies in the first place. So we don't mount an immune response to small molecular weight things. So any of the toxins that are less than 10 kilodaltons, which there's a handful of, are essentially not going to have any reversal by antivenom because the host animals just don't make antibodies to them in the first place. Just things that mimic endogenous compounds. So like phospholipase A2 enzymes and metalloprotease enzymes, we already have those. The snake ones are somewhat similar in structure. And so we don't necessarily develop tons of antibodies for them. And so the effectiveness of antivenom on those is very limited.
So even within our own state, the map that you had of the varying types of rattlesnakes or types of venom that's available, somebody getting bit, say up in north, and then all of a sudden they're down south. Could be completely.
It could be.
different.
There's definitely a hypothetical basis that could explain it.
Okay.
The kind of the simple takeaway is that as the dose goes up, the paraspecificity tends to get better. And that's kind of the argument for using like higher escalating doses to try to stop something even if it's not stopping.
Interesting.
We got a lot more questions to get through here, but
I
keep
don't
going,
have any
so
if
yeah.
I wanna jump, no, I won't, we wanna get the questions first, all of our stuff can wait. All right, so the question for you, do we have the brown recluse in Arizona or a distant cousin? I've heard it both ways over the years, and regardless of which we have, is there a difference on venom?
Oh, I know much less about the spider venom. We have some type of Arizona brown recluse. I've seen folks at museums handle them with their hands, which, you know, as a toxicologist always makes me concerned, but they didn't get bit and they seem to be very confident with her. But there is something here, as far as bites go, they're relatively rare. I've been called on questions of ones, but I've never had any like persistent necrotic wounds or any of the things that people worry about with the brown recluse bites.
Okay.
Where they live, the classic thing is that they're like in clothing that's been in the back of the closet for years and years and years, and no one's gone back there. It's when people clean out their closets or storage sheds and have all this old clothing, that's when they encounter them. Outside of that, allegedly, you're not supposed to encounter them.
Anything to say for that one, Dr. Klotz, or anything to add for the brown recluse? But you're still
might-
muted. You might want to
You're
unmute.
muted. You're muted.
There it
There
is.
is an Arizona recluse. The one that's in the Midwest and is the most famous and widespread is Loxosceles reclusans. But in Arizona, we have a smaller, browner recluse that you can see out at the Desert Museum. They have them. And they're poisonous, as are the others. But it's Loxosceles Arizona, I believe. And not much difference is known because people are rarely bitten in Arizona with this. We have a lot of black widow bites, but not
Brown recluse.
brown recluse.
Interesting. All right. Does the neurotoxin have a long-term effect on the body? And the double on this question, that was my question at the very beginning, as you mentioned, some folks you're following up with still have these persistent issues. What are those issues looking like typically that you see?
Yeah, so possibly. We don't really see the flaccid paralysis, which is the thing that lots of folks have been worried about for a bunch of years around here, but we do see the neuromuscular excitation in a certain number of folks. And again, I suspect that worsens the tissue injury. What we see is that they have some type of persistent pain. And it gets difficult to tease through, right? Because you have lots of baseline reasons why you might have chronic pain. And we don't have huge enough numbers to really have like a definitive understanding of it, but it's on the board in my office of things to get a better idea of as we move forward. So I characterize kind of recovery from physical injury as pain, swelling, and function impairment, but there's lots of subtleties in there. Paresthesias, whether or not they're like shocking paresthesias or constant dull aches. When you kind of get into the qualitative components to it, there's a lot of different things that people are reporting, and they may all have different etiologies. We're not really sure. I would probably say that persistent kind of dull aching pain is the biggest long-term thing that I would say I suspect might be related to it, but that's just a guess today. That may or may not be at all accurate. So, how expensive is the antivenom? So the typical hospital course runs around $120,000, but most of that bill is really just the ICU time. So I mean, there's all this voodoo that goes into a hospital bill and what was charged and what the hospital paid versus what the billing is, and then what the insurance actually pays in the back end. That's its own lecture series right there, but
Oh, God.
the antivenom, for the sake of purchasing it, is probably less than $1,000 a vial for the hospital system. If that helps people get an idea of how much it costs. Even if you get 20 vials, I mean, the cost of the hospital system is probably less than 20,000. There might be exceptions to that, but as a simple rule to kind of guide things, you know, if you got $120,000 hospital bill and got 20 vials of antivenom, that wasn't antivenom. That was 3 days in the ICU. Now, whether or not you need to be in the ICU for 3 days is a very different story that I've been trying to shed some light on, because I think there's a lot more efficient ways that we could treat patients. But again, unfamiliarity kind of leads to over cautious treatment. So.
All right, I think that's the end of our participant
And of our
questions.
specific questions, the
Yep.
one that caught my eye from the pharmacy perspective, so what would be some reasons for doing both, GoFab and N? That's interesting.
So I had a paper, it came out like last month, I think it was, but what I did is I looked at antivenom effectiveness. And so that's where this kind of tissue injury equals pain, swelling, and function impairment. I made this categorical system and I had this composite score. And so I looked at about 5 years worth of patients and I said, if these things are equal, you know, all things held equal, the recovery at day 14 should be the same. And so I looked at a couple hundred people of each antivenom, and when I compared them, I found that they were not the same. Now, this was a null hypothesis study, so it was, you know, I had no reason to suspect a difference. I controlled for some recovery things like diabetes, and then when I found a difference, now someone needs to explain why. It's possible that they have different effectiveness with regards to local injury. So CroFab had better recovery. More people with CroFab had a full recovery faster. If you go looking in my name in 2025, you'll find this paper. It was in JSEP Open, so it's public access. So it was about a third or so of CroFab people were recovered at 14 days versus about a quarter of Anabib patients. And just some of the various ideas we had as to why we might have observed that are in the paper, but CroFab might be better for local injury. Anabib definitively is better as far as late coagulopathy, and that it just doesn't have it. So again, our current practice is everyone has to get Anabib. If you have a local injury that's not responsive, or even perhaps in a more ideal setting, CroFab might be better for the local injury piece. An area of, new study moving forward.
Yeah. And then what would you guess is the mechanism behind why maybe NSAIDs might do better than these heavy duty opioids?
Sure. So I mean, the NSAIDs might suppress the inflammatory response that's driving a lot of the injury. It's just a simple mechanistic maybe. It might just be more effective at the analgesic component to it. We haven't really looked at like NSAIDs and local injury to try and see if it seems to impact it. It's rather difficult to predict things in this disease state because of all the confounders and the lack of objective diagnosis of what toxins are there. But we have some suspicions and we're working on ways to kind of work around the inability to know what toxins are there. But just anecdotally, Toradol seems to do wonders for folks despite several doses of opioids. So that's my personal go-to after I kind of screen for a couple of things to make sure I'm not worried about causing bleeding problems.
Let's see, any other questions for y'all? Going once, going twice? I had one other, but it's already left my Swiss cheese brain.
Well, if we have more questions, please put them in the chat. I do want to let you know that next week on August 6th will be our next session, and that's going to be on mosquitoes. And then we also have one coming up in September on the 17th, and that one is going to be about the mighty mites. We'll be on that one. Dr. Klaas and Dr. York will be talking. So I believe that that got sent out in my email. We got all three of those set up. So please go ahead and check our website and get registered for those if you haven't yet. And again, all this information, the links, the recording, the link for the recording will be in my thank you email to everybody. We got another comment in there.
Can we do one on scorpions? We have done so many at this point. I think we've done scorpion. I even think we've done brown recluse. If they're all bleeding together, but I think we've done them. So do double check our, what would you call, I guess our archive.
The archive, the previous, yes.
Yeah,
webinars.
they're all posted on YouTube, but you can get the links through the University of Arizona telemedicine website. But if there's anything, if you want an update or there's some curiosity, please let us know. And this is something we've brought back with some updates. No reason we might not do that for other topics as well.
Absolutely, and please go ahead and, thank you, Chris. So there's the URL to our previous webinars that Chris just put into the chat for us. I will also have that in my thank you email to everybody so that you can access that. And we have a search function on our previous webinars so that we can, so you can just put in scorpions and then all the webinars that will pop up. Hey, we got another one on hantavirus.
Oh, an update on hantavirus as the cases have increased this year. Honestly, I think we're gonna probably see a lot more presentations in the future on some real weird stuff. We got plague cases, we got hantavirus stuff. We're gonna cover some nasty, creepy crawlies, and then honestly, I bet we might revisit some of these unusual things, but I think we have talked about hantavirus a bit as well. But double check.
Double check that one, right?
Yeah, I'm gonna be honest, they're all bleeding together, but I think we might have. Don't quote me on it.
Dr. Klaas, do you have any comments you'd like to add?
Yes, I'd like to thank Jeff for an absolutely stellar talk. He's always a very good speaker, and he explains very well how things act and what the contributions are of the different components. And that's so important in understanding envenomations because they can be very confusing. They can look like anything, as a matter of fact.
Yes, I spent a lot of time trying to dispel stuff and I've practiced my speeches a lot here. They didn't always go so smoothly, but thank you, Dr. Klaas. I appreciate it.
Yeah, absolutely.
Interesting. Do you get a lot of pushback on certain things or myths?
It helps to be able to dispel them with simple words that make sense.
All right, another comment, lots of great information. Thank you. We love bringing this program to you and, talk about biting midges. Dr. Klotz? You heard about them?
They usually don't bite. A midge. A midge.
A midge doesn't bite? What are they?
What?
What are they? What is a
Well, they
midge?
look somewhat like mosquitoes and they come out of the water. I mean, water is part of their life cycle. And the mature adults fly from there. And they're rapid flyers and they're kind of annoying, but typically they don't bite.
Gotcha. And
Which
it looks like they're referencing up at Dead Horse Park up by Camp Verde. It's one of the state parks,
I
campgrounds.
wonder what species they're talking about. I'm not sure.
Okay,
Typically they don't.
We'll take a look.
we'll take a look on that.
All right.
All right, everybody. So we're about wrapping up here. Again, thank you for joining us. Again, thank you, Dr. Smelsky, for the excellent information on rattlesnakes. And Dr. Klotz and Dr. York, it's always a great pleasure to work with you and see you. Again, so join us next week. That's a week away on August 6th. We'll be talking about mosquitoes. And I believe, wasn't there some increase in West Nile virus going on in Maricopa County?
Don't quote, that sounds familiar.
Okay, all right. So we're gonna be talking.
What happens then? That's your answer.
So we'll be talking about mosquitoes in August, and then we're talking about some mighty mites in September. And we do hope that you will join us again. Oh, it looks like they were told that what was bit all over exposed area, and someone had a severe allergic reaction to some kind of a midge or something that was biting up at Dead Horse Ranch Park.
Probably black flies or some mulids.
Okay. All right. All right. With that, I think we're going to go ahead and call it a day. Thank you, everybody, and we'll see you in a week.
All right. Bye now.
Thanks, everyone. Bye.